the lecture is going to be on care of the LGBTQ community. Objective: discuss concepts related to gender identity and sexual orientation, identify determinants of health or factors of health affecting gay, lesbian, bisexual, and transgender individuals, describe health promotion, illness prevention measures to care for LGBTQ population and population outcomes, identify areas of focus in resolving existing health problems in the LBGTQ population based on nursing goals, and describe or considerations relevant to healthcare for the LBGTQ population and their population health and nursing goals. So defining the LBGTQ population is hard because a lot of it is underreported, understated, because people are scared to make themselves aware and sexuality is aware. There's a high stigma against this community. The population accounts for 1.3 million, but that number is actually higher because of the underreporting. And by 2030, it's expected that there will be 6 million people a part of the LGBTQ population. Some statistics. In 2006, 53% of new HIV cases were men having sex with men. And of that 53%, 93% were black men having sex with men. Women having sex with women and bisexual women has an increased risk for chlamydia versus heterosexual women. And 3% of the LGBTQ population are people from the ages of 18 to 19 years old. And I'll talk a little bit about it later, but when it comes to adolescents, a lot of them don't go with either homosexual or bisexual. They can be a little bit of both. Terminology is really important because when you're out there in the community and you're talking to this population, they want you to know these terms, know what to call them, what they are considered. So sexual orientation is self-explanatory, whatever your sexual partner you prefer. Gender identity reflects whether you consider yourself a male or female, or boy or girl. Side gender, which you'll see in the video a little bit later, is the individual who kind of goes with what their birth sex is. Gender expression is how you express yourself. Gender non-conforming individual is a person that doesn't go with the norm of what society says your gender should be. Transgender are those who does not go with their birth gender. And transsexual are those who believe they're in the wrong body. You'll see on the video, they talk about this and they want us to know these things, and you as a nurse and their role should know these things to educate other people around you. Terminology. Then MTF is transgender female, male to female, and FTM is just transgender female to male. Psychosocial impact on LGBTQ community. Stress is an issue because they're coming out, they're not accepted in a lot of places. So they're stressed out, which puts them at risk for suicide, which is high in their community. They have health problems as well. For the transgender community who take hormones, and taking hormones, they have changed in their bodies and they don't get preventative care. They also partake in high activity, risky high activity, which is drugs, alcohol, and sexual activity, which puts them at risk for HIV and STIs. Post-traumatic stress for this population because of the abuse that they go through, because of the assaults that they go through, whether it's physical or whether it's sexual. Low self-esteem and depression is a part of this population. It's a huge part of this population, especially for the adolescents. So years ago, when you were transgender, they gave you a psych diagnosis of gender identity disorder, which means that it should be cured, something that should be cured. So the LGBTQ community kind of fought against that. So they changed the term to gender dysphoria, which means that they'll get assistance for dealing with the stress and the identity of being who they are versus a psychiatric disorder that needs to be changed. Sexual orientation it just describes perspective. Anatomical is their body parts, chromosomal is just your gender that you're given, hormone is the hormones that you see, which help form your female parts, and psychological, how they felt after in their mind.
So when we're seeing them in clinical, how do we know which perspective we're dealing with? Do you know what I mean? Like generally nurses aren't thinking about the chromosomal.
Like the data.
So we have to ask the client.
Well, some of asking the client knowing who they are. You want to know who they are, you want to meet them where they are, and the only way that you know is if you ask them. How do they look at themselves? What do they determine? How do they determine themselves? Environmental factors. In rural areas, there's a decrease in support. Environmental factors can also be who they've been around coming up that can affect their sexuality. Culture and social determinants. Homophobia and heterosexism. Homophobia and heterosexism plays a big part in this community because people that are heterosexist feel that their heterosexism is above everything else, so they treat people different. Same-sex marriages. We have same-sex marriages in some states where you are allowed to get married. It's okay, but for those states where you can't get married, that becomes an issue, especially in healthcare. Tax benefits plays an issue if you're allowed to get married in your state or not. Psychological distress, mood disorders, they have a lot of because of the stress. So you as a nurse want to try and get them counseling, you want to try and talk to them, trying to get them to have positive coping mechanisms, because a lot of their coping mechanisms are negative, which is drug and alcohol and using sex. Anxiety is high in this population. So as a nurse, you want to talk to them, make it easy, earn their trust, gain their trust so they can be open with you. Substance abuse is high in this population, which I mentioned.
So the issues related to psychological distress are not because the person is LGBTQ, but rather because of the way society treats them. So that's why it's important to know that it's not inherent, but rather if they weren't experiencing all these societal stressors, they wouldn't be having mood disorders, they wouldn't be experiencing anxiety, and that much of the substance abuse is kind of like a dual diagnosis in terms of dealing with their anxiety or depression or other issues. So it's important to separate those out, because just because you're LGBTQ doesn't mean you're automatically going to have those other kinds of stressors. It really depends on the environment in which you live and the family that you're brought up in terms of support.
Right, whether you've been accepted by your family. Family interaction, to allude on which Dr. Nate just said, is very important, especially when they're coming out, whether they're being accepted by the family, whether they're not. Adopting children is an issue sometimes for the LBGTQ community because normally there's a mother and a father, and normally female adopting. But then you have people of the same sex who want to adopt, sometimes that can become an issue. Informal caregiving, a lot of times in a lot of states, same-sex partners aren't recognized. Unemployment and poverty is an issue because if they are having those issues, psych issues, whether it's drugs or it's alcohol, or coming out to their co-workers and they're treated different, they can get laid off or they can get fired. Violence and hate crimes. With this population, there's increased violence and there's hate crimes. So a lot of it is sexual abuse, and sexual assaults are vicious. More vicious than it would be when a person that wasn't a part of this community PSTD that they have. Intimate partner violence in this population. You're seeing a lot of different sexual orientations, but you see a lot in this one. Behavior determinants, sexual practices. So serial sorting is when two people decide they want to have sex, and it's like an honor system. You ask, whoever you're going to have sex with in the same sex, whether they're HIV positive or HIV negative. Serial sorting is going off of we're both negative, so it's okay to have sex, which to me is not really a good thing, because if they're not being honest, then that becomes an issue. Versus condom use. They go for serial sorting sometimes versus condom use. So you want to educate them on it's not a good practice to have, because you don't know who's being honest and who's not. Substance abuse we talked about, as well as alcoholism. You kind of turn to that as a coping mechanism because of the stress, because of how they're being biased against and discriminated. Some health system determinants, barriers to health care, internalized stigmatism, which again talks about on the workplace.
Sorry, can we go back? Can you explain this
Zero sorting.
Yeah.
Zero sorting.
Can you explain that
That's
again?
when it's like an honor system. So if two people decide they want to have sex, they'll ask, do you have any STDs or do you have HIV? And if they say they're negative, they both say negative, then they don't have sex, believing what the person said. So internalized stigmatism in the health system, and you'll see a little bit on the video, which I'm going to show in a minute, about heterosexism and homophobia. Expectations of rejection. So they're rejected at home a lot of times. They're rejected by friends. They're rejected by peers. So they kind of expect that. So you as a healthcare worker, you kind of want to earn their trust and not treat them in that way. Be kind to them so that way they can talk and just let things out. Expectations of rejection can lead to homelessness and job termination. IOM recommends culturally sensitive health care. One thing that they recommended, they wanted some of the language to change as far as the pronouns. He, she to Z, and him, her to her, which has not been accepted yet. So here's a video that I'm going to play, which gives you the community talking to, giving their point of view.
My name is Leo Sell, and my pronouns are they, them, their.
My name is Sophia Stanford, pronouns she, her.
I'm Gray, and my preferred pronouns are he, him.
Robin Kanawar-Haza, and I use feminine pronouns, so she, her, hers.
My name is Luke Jude, and I prefer he, him pronouns.
My name is Chloe Flora. My preferred pronouns are she or they.
"99% of the time when I go to the doctor, I'm anxious and nervous.
Even though insurance and driver's license and everything says female, you really don't know what to expect.
Yeah, I don't think I know any trans person that went through the medical system and had a nice time with it. Not in this country.
I haven't gone to the dentist in 4 or 5 years because it's just such an uncomfortable experience.
I know people who, if they sprain their ankle, will just wrap it up and put some ice on it rather than going to the ER and having an x-ray done because it's just not worth the stress.
I had a history of urinary tract infections. It was pretty commonplace for me, and I went to the urgent care, and the physician on staff that I was dealing with kept telling me over and over how atypical it was for a man to be having a series of urinary tract infections. I tried to interrupt him and say, I understand, I've been through a gender transition, so my anatomy is probably not what you expect it to be. And he kept stopping me. He wouldn't let me complete and assuring me that he did understand. And he said, I think I would like to take a look. So I pulled down my pants, and it wasn't at all what he expected. And he was immediately apologetic. He said, oh, you don't have, I'm so sorry, I didn't realize. I said, I know, we tried to tell you.
I initially knew I identified and felt female around 5 years old when this was caught out by my family member who was the director of mental health for the state that I lived in, essentially required forced correction, like invasive hypnotherapy, corrective assignment and orientation to gender roles, other things to help masculinize and or reprogram the viewpoint of the world to the child. If I have to be this way, I'm going to walk in front of a car and I'm going to reset it and try over. That's what I thought when I was 6.
I had a bunch of different symptoms tied to sleep, tied to appetite, weight gain, mood, that had sort of increased in severity over a year. And one of the things that my doctor told me to do was check myself into a hospital next time I had my round of symptoms. So I checked into a hospital, and even just within the check-in process, I was misgendered. I finally spoke to the doctor, and he came in and was speaking to me as if I was a 13-year-old girl. And all of my symptoms were surrounding hormones. And when I started talking about hormones, this doctor in the hospital actually looked at me and said, oh, what do hormones do? I didn't think hormones did anything. And he actually checked me out of the hospital. He said, I think that you're just bleeding a lot right now. Fast forward 3 days later from this hospital visit, and I was diagnosed with invasive hormonal breast cancer that tested 99% positive for estrogen. And I think that if I had had the same list of symptoms, but was a cisgendered man, I would have been treated completely differently.
So in general, I've been blessed with a good primary care physician and an endocrinology doctor, but I was seeing a specialist for a different medical problem, and my records and everything all said female. I have everything changed. And the guy looked at it, he went through all of those steps, and then said, "So, do you dress full-time as a woman?" And I was stunned. It's like, "Do you dress full-time as a man?" Yes, I'm a woman. I'm a woman with transgender experience, and of course, it's just like any other woman in your office.
The biggest horror story that I had was going to the pharmacy to pick up my first testosterone prescription. I was nerve-wracked already because it's like such an emotional thing to like finally get that golden ticket. It ends up being like $1. So it's just the syringes. There's no medicine. 4 people later, in about 20 minutes, they finally look it up in the computer and they're like, "Oh yeah, oops." Throughout this entire process, I have to say my legal name, which isn't the name that I go by, out loud to the entire store. And I'm basically outing myself to everyone around me. And that's not wanting to hide, that's just about trying to stay safe. Like, some people hear that and they might follow me to my car and bash my head in.
During one physical therapy appointment, I had one of the therapists misgendered me to an entire room of people, both other physical therapists and other clients. He never looked me in the eye again. He never talked about it. He never apologized. It was just this weight. And especially me as a trans woman, I get misgendered all the time. Like, it's something I deal with on a near daily basis. So to have that happen in a medical setting, something where I can opt out of, even though it might not be the healthiest thing, I will. I'd rather protect my own sense of mental health.
So this is how we make them feel, not us in this room, but people in the healthcare community when they're not educated. So learning the terms and being educated to help those. Is important so that we don't treat these people this way. Other health-related issues is silicone injections. A lot of times to change your body forms, they inject the silicones. Where's they getting the silicone from? Where are they getting the hormones from? Probably put it in there. Are they proper? Are they right? Sometimes they share syringes which push on that increased risk. And they don't get HIV testing as much as they should, at least every 6 months or so. So we have to educate them on it. We have to be educated to educate them on it. So IOM, the Institute of Medicine, has enacted, personal barriers to LGBT healthcare, enacted stigma. Explicit behaviors on the part of healthcare providers that express stigmas, such as denial of care, provision of inadequate care, or verbal abuse, which is seen, which they talked about in the video. So the ACN, American Association of Colleges and Nurses, they have essentials to baccalaureate education, things that they feel that essentials that needs to be taught. I felt that Essential 6 is important as well as 8 is important for this community, which is interpersonal communication for improving patient outcomes, which a lot of these clients and patients here did not receive, and professionalism and professional values, which a lot of these clients here did not receive in the video as you saw in their testimonies or in real life. QSIN, Quality and Safety Education for Nurses. They have competencies, and the competencies talks about patients and the care team for collaboration and quality improvement for all. But in this community, it's not seen. The testimonies to you, if you talk to other LGBT people in the community, they'll let you know that it's not seen, it falls short, and we as nurses need to get better to educate. This also leads to us needing more education in schools. When I went to school, we didn't have none of this. A lot of doctors, when they went to school, they didn't have any of this. It needs to be taught more, so at Wiley, it's pretty good that it's taught here to help us help this community. NCLEX blueprint. So when you take your NCLEX as a whole, is a blueprint of things that need to be discussed. Management, client rights, crisis management, coping mechanism, lifestyle choices, abuse and neglect. All of those things are very important to all, but especially to this community because this topic is sensitive. They already are mistreated, so we have to go through the blueprint and make sure that we're educating in all these areas for these patients, for these clients to be better with them. The Transgender Law Center in 2011, they have principles for designing healthcare services to meet the needs of the transgender community. They're underrepresented and underserved. creating or adapting cultural sensitive services. That's something that we can do. Involving leaders for the LGBT community. So when you're out there and clients come to you, or you go out and you talk to clients, there's always a leader that they may mention. And you can speak with that leader because they're the best ones to tell you what the community needs. When you try to help them to go forward, to go to Capitol Hill and talk to policymakers. Culturally created literature. There's literature out there that in offices or where you work, you can educate yourself on as well as others, and have things posted so that when they come to the office, they feel a little more comfortable. Healthy People 2020 has 2 developmental objectives related to LGBT health. One is to increase the database, the amount of people that's in the database, in which it comes to underreporting. Transgender population, health status of the transgender population is not really put out there, but we need more information. Just some more health factors for lesbian women. They have higher risk for obesity, which leads to cardiovascular disease, which leads to overweight, being overweight. So we have to educate them, especially those transgender females who are taking hormones. Because with those hormones that they're taking, the increased obesity for them, it increases them with cardiovascular risk. That's likely to have children, increase in chlamydia in this population, increase cervical and breast cancer. And some of it is from not getting preventative care. For breast cancer, when you are transgender male, if you take the hormones, you're gaining breast tissue, they have to get breast exams done as a preventative care. Male to female, I mentioned, increased heart disease, increased stroke, increased breast cancer from the hormones that they're taking.
So we just need to reinforce again, it is not because someone is lesbian or transgender that you're at greater risk for chlamydia or breast cancer. It's because they fear the healthcare system and don't get preventive care. That's the reason. So it's important to differentiate, we're part of the problem for why we're seeing these increased risk of infectious disease. The other misnomer is that sometimes people make the assumption that sexually transmitted disease is a heterosexual thing. That you only get it, in that type of arrangement. When in fact, again, domestic violence, sexually transmitted disease, it crosses all those barriers. So it's important to, again, encourage people to get reproductive care. What is one of the reasons that women go to seek reproductive care? Or any women's health issue? What's the primary reason women go for their PAP and their... Most of the time because they're seeking birth control, right? So if you are transgender or you're lesbian, you may not be seeking out birth control. So therefore, it's not a natural, it's not part of, your daily thought about, oh, I've got to get into the doctor. And because of that, you have to raise the awareness about the fact that you need those preventive services. And there's not that natural cue, you need to renew your birth control or you need to go in for that exam in order to get the script. So again, it's not those things to help remind them. So that's why we really have to pour more money into those preventive services because the general public doesn't understand that either. And so we miss lots of opportunities to be providing health care when we should be. Thank you.
Some other health factors, LGBT community are at an increased risk of suicide attempts. Sexual assault is increased as well as use for punishment or correction against this community because they feel like something's wrong with them. So I'm going to punish them. I'm going to try and correct them, like the man talked about in the video. Men having sex with men and gay men are at increased risk for anal rectal cancer. So getting those anal smears for cytology is very important. Need to be promoted in this community to look for anal rectal cancer as well as HIV testing. In adolescence, homophobia and heterosexism increases health disparities and mental health with increased rates of depression because they're afraid to come out. They're afraid of what they're feeling also. They don't know what they're feeling, they're afraid of it. Suicidal ideation, altered body image. So they have the silicone injections to alter their body image. Substance abuse, STIs, teenage pregnancies because of unprotected sex. Increase in HIV from the unprotected sex as well. So we have to educate them and talk to them to see why they feel the way they feel. Give them counseling to help them. Also give family counseling because some of them are homeless, like I talked about on Monday. get counseling, family counseling with them to try and help them get to rapport. Transgender females, increased risk for SDIs as well as HIV, and there's an increase in African American and Hispanics over whites. Increased incarceration because of psych issues, because of behavior issues. Homelessness, exchange sex, survival sex is another thing we see a lot in this community if they're homeless, if they're out on the streets. Non-consensual sex, difficulty assessing health care, especially if they're transgender. A lot of doctors aren't educated on that. So they may refuse care to clients because they don't know how to care for them. Silicone injections, I mentioned, and sharing needles for hormones. So we have to educate them on not sharing needles, not getting these hormones, because if they're not with their parents, where are they getting hormones from? What are the hormones that they're injecting themselves with? What are the side effects? What are the health risks of these hormones that they're taking? So for the adolescent community, if they are abstinent, we want to educate them on maintaining that. If they are sexually active, we want to talk to them about having safe sex. They have no definition, men having sex with men as well as women having sex with women. They can go either way at that time. Sometimes, a lot of times, they're undecided. Gender dysphoria is going to be their diagnosis. They're ostracized, leading to homelessness and survival sex as well that I mentioned earlier. Because if they're homeless and they're out there and they need to survive, they can have survival sex, which puts them at risk for alcoholism because of the cocaine, because of the stress, HIV, and STIs. Here's another video of adolescents giving their point of view.
I mean, there's so many journeys that exist. I mean, we all have a different path, and and trans identity is only one, and no one is wrong for how they understand themselves.
My name is Danny. I work at the University of Michigan for a couple different programs. On this project, I'm working with the Adolescent Health Initiative to get information about what it's like for transgender young adults to navigate the healthcare system in hopes that we can work to make it better. As a transgender person myself, I care a lot about educating people on this issue and improving our healthcare services, especially because many trans youth are at high risk for depression and suicide. For this project, we met with transgender young adults in the Ann Arbor and Detroit areas to hear their experiences with healthcare. We recognize there are many other viewpoints not represented here and do not intend to speak for the entire transgender community. This video was created as a companion to trainings by the Adolescent Health Initiative for healthcare providers and staff. It's our hope that sharing these perspectives will help you better understand some of the challenges faced by transgender youth so we can work to improve the healthcare system.
I would like to be asked what pronouns to use, because for me, when somebody says he, it really, really upsets me and almost like breaks me down, and then it's like, oh, I might as well just leave because I'm sure I can handle this on my own. I came to you for help and you just, ruined my entire, week.
Jordan, when would that happen to you? Like, when would it feel best for that to happen? Is that like over the phone? Is that on the form?
I think on the form, because that would be a little bit weird to be, what pronouns do you use, making your appointment? I feel like that would be a little bit too in your face.
Have you ever encountered problems filling out forms or like frustrations with having to like check certain boxes?
Yes. That male, female box, yes, because I want to mark female and legally I can't, and that irritates me. Or I might be on the phone with them and they may say, well, what is your gender? And I have to tell them what my legal gender is, but that really frustrates me. It does.
Do other folks have similar experiences with that or different experiences that you would want to talk about?
They actually asked for your preferred name, and I put it down. I was like, yeah, they're gonna use it, and they didn't. And I was like, so what was the point of me putting it down if you're not gonna? So yeah, I get that there's the good intention, but you're not gonna implement it. There's no point of putting it there.
If you could list off just 5 words or terms that you would like your healthcare providers to know or be comfortable with and do some education on their own about, what would those words be?
Those would probably be cisgender, transgender, gender nonconforming, cissexism, transphobia.
So just learning those things would be good.
Yeah, oh my goodness, please learn them.
So cis or cisgender is someone who identifies as the sex and gender that they were assigned at birth. So that's when the doctor sees the baby and they're like, oh, it's a boy, or oh, it's a girl. They still identify as whatever the doctor said at the time.
I'm not big on terms. I just like for people to be respectful. As far as like, if you don't know, pull me to the side and ask me. Or if you think you know and may have an idea, still pull me to the side and ask me. Don't be like, oh well, she looks like a she is, or is she a he, or don't try to guess it. Like I said, I'm not really big on using terms. I just use female, and I may ask you, or I'd rather just use your name. You don't know what we're going through, and a lot goes on in our heads because we have to deal with the world accepting us being transgender, and health is something that is a big concern with us.
I think for me, one of the biggest problems I encounter is that whenever I go to the doctor, I end up telling the doctor more about my body than the doctor tells me, because they just don't really understand stuff or understand how things work, which I get, but also it's kind of their job to know. And I feel like, I know that like hospitals are supposed to provide training for them and stuff like that, but they don't. And so it ends up being, because trans people's bodies and what they're experiencing and what cis people go through are totally different in a lot of ways, but in a lot of ways they're not, and they don't really know where that is, and what kind of boundaries those things have. And it just gets really weird sometimes.
Can you just talk a little bit about what it feels like to sit in the lobby?
After you then signed in, and especially like me, I don't have my name changed legally done just yet. My gender marker is not legally changed either. So it's kind of hard for me to have to sign in and, give up all my documents and stuff like that. And when not, I retrieve them back and then wait patiently for the doctor or somebody to call you out. And then you're just waiting on that door to open, and you're just like, oh God, what are they going to say? What are they going to say? How are you going to do this? And then when they call your name out, you kind of don't want to just sit there, because then they're going to look at you and be like, hey, they just called you. No, they didn't. No, they didn't. No, they didn't. Wrong person.
I just wish that their kindness extended to trying to find a level of understanding with their trans patients that I just don't think exists for a lot of doctors, because it's so amazing and frustrating to see those wonderful intentions and then just still leave really upset.
Yeah, a trans-friendly doctor's office would be people who are culturally competent, people who actually, I feel like if you don't have a desire to be affirming of different identities, then don't be a healthcare worker.
Statistically, you're going to have quite a few trans people entering into your office, so that's a lot more common than your very, very rare disease that you might spend a month studying at your medical school. So it's not just this, one tiny segment. If you can learn and study about a very rare disease, that you can also learn and study how to be respectful and polite to trans people when they come in.
Now is more of a time than anything to want to get on the bandwagon of trans healthcare. Because it is happening, it is out there, and more folks are coming out, not necessarily at, 30, 40 years old, even 20, consensual, I should say. People are coming out younger and younger. I Am Jazz is 7 years old. You actually take the time out to really focus on, what your client or what your patient's, needs are, and you really have that, oh, okay, I can do this, because it's not really that hard, it's not that difficult. Or even if it is something difficult, challenge yourself. Challenge the medical system. Challenge the healthcare field. Do it. Because what's the worst they're going to tell you? No.
Adolescent health promotion, self-esteem, as we know, is going to be, yes.
Can I say something? What did you guys feel when you saw this? Because that's an important question. What did you feel? We all have biases. Remember, we talked about that. So if you don't come to grip with your own biases, you'll never be able to care for another human being, regardless of how they identify. We've got to learn to put that thing aside. Okay, so, because I could feel that back here, and everybody was like, oh my God, I hope she doesn't ask me any questions. You know, but you need to come to grips with that. And it's okay to feel that way. But you need to know that you can't stay there. Because somebody, maybe one of those people will need your help. So how will you help them? How will you help them? Just some thought as you go through. Remember, it's about health promotion. When you guys you're going to have questions like this on the NCLEX. And you got to put your biases aside to recognize what the question is asking you, and then to answer it. Does that make sense? Okay. Sorry.
To your point, you have to put your biases aside. It's like if you take care of a serial killer or someone who just hit a kid. You may not want to. They could have been your neighbor, but you still have to care for them, and that's part of maybe what someone is feeling, and maybe not what they feel all the time. So they don't come out. They don't speak out when they're about important. They say limited things instead of saying everything because they feel that bias and discrimination. So they put their guard up. We have to help them get their guard down because they do need to be cared for a lot. Adolescent health promotion, self-esteem is low in this population. So we're going to talk to them. We're going to make them aware also that their care is confidential. Anything that they tell us is whether they want to come out to the doctors or the nurse. Because we are the most stressed occupation, so people do tell us things. We can let them know that we are not going to tell your parents how you're feeling and what you're feeling. Use gender-neutral terms with this population. We reinforce abstinence with this population. I can't say how important that is. Encourage safe sex. Encourage them to get their cytology screens if they're doing it in adolescent age, which is here, so they should be. And HPV vaccine. Make sure that they're getting these vaccines. Stress factors that impact LBGTQ community, social support, lack of social support, lack of the community reaching out to them, lack of family support in a lot of people in this community, lack of legal support. What is their legal stance? What if they have a partner? Like, what can they do if their partner is admitted to the hospital? A lot of times they can't do much of anything. They don't go to the children or the parent versus their partner. Bias, discrimination is there. It's obvious, they see it, so they brought up, like I just mentioned. We have to help them as nurses, because regardless of what we think, like Dr. Brown said, we have to help them with whatever their issue is. Whatever we think the belief goes out the window, we have to help them. Screenings we're going to encourage, because they don't get preventative care. They don't go to screenings, HIV, STI screenings. A lot of times if they go to the emergency department, part of the triage is to get an HIV test. We can make them aware of places where they can get screenings done. Pap smears are very important. Mammograms, prostate exams are going to be important. Refer them to places that offer them free if they don't have health insurance. Or if you know of a place that are going to be more kind and professional is the word to this community, you can refer them there. Lack of preventative care, I mentioned already. We want to promote condom use. One thing that I saw in the literature is condoms in the gay bars that we can kind of promote or advocate for. Because if we have a condom, you're more likely to use it. If you don't have one, you're less likely to use it. They put you at risk for everything that I mentioned earlier. Health promotion, nutrition and physical activity. Eating right is going to be popular for this community, especially if they're taking certain medications. Developing positive coping strategies instead of the negative coping strategies. We want to promote, find what they like to do, offer them new ideas of things that they like to do, they may like to do. Measures to prevent HIV infections, which is going to be using using condoms. Promotion of silver-sorting strategies. I mean, it's here, it's in the literature, they say you can promote that, but you need to know, they need to know who the other person is that they may have sex with. Are they an honest person? Are they really going to tell the truth, or are they going to say anything just to get what they want? So we have to educate them on that. Promote safe sex practices, strengthen partner relationship to monogamy instead of being promiscuous, which will decrease their risk of HIV, STIs. Medical treatment for transgender. So a lot have surgeries. One is phalloplasty, which is the formation of a penis. So as the nurse, you want to educate them on post-op issues that they may have. They're going to get educated before, but if you're going out in the community and seeing them at home, you want to reinforce the education of the no sex, of the fact that they will have I'm sorry, got distracted. Going to educate them on post-op. that they'll have a urethra for a year, no sex until they're cleared by the doctor. So you want to reinforce and educate them. Because a lot of times the patients go home with the surgery, they kind of do what they want, but you as the nurse going out, you want to reinforce the education. Prostatectomy and having sex afterwards, you want to educate them on that they can't, if they had their prostate taken out, they cannot. Even though they may want to, they cannot. Assist with your ID change and or changes in their birth certificate. You can help them with that. Room assignment, admission room assignment. So when a transgender patient is admitted to the hospital, and you're that case manager, or you're at, in the patient's home, and you're calling to get this patient admitted, what room do you think a transgender female should be placed in?
I didn't.
Your female room? Okay, so what if that, because when you're in the hospital, there's double rooms, it's only curtain. The neighbor's going to get all your information. So what if that female hears that, oh, this is a transgender female, but they still have male body parts? So they think they're in the room with the man. I can't hear you. That's the goal, to try and get them a private room, which is very important to know the patient coming into the transfer center, giving information to them about where to place the patient. The goal is going to be a private room, so there's no issues with either end. But an issue with a private room can become a factor if you have a patient who's in isolation in a private room. They may have to, maybe have to be moved or not, but no, they don't get
How would like you as the nurse like handle that situation if like the neighbor doesn't feel comfortable with like a transgender person in the room with them, but like no private rooms are available? Like, how would you handle that situation?
Then you would have to talk to your charge nurse or the supervisor about that issue, even if it's to another floor. So the role is going to be as the nurse to know the pronouns, to know the client, to know the terms, so that when you're talking to them or you're talking to your coworkers, because you also educate your coworkers, you kind of know so that when they come in, they can feel a little more comfortable. You're going to encourage the LGBT community to discuss their experiences, like on a video that gets it out. That can be a stress reliever for this population. Provide emotional support to them. So when they come into your office and they're talking to you or you go see them out, you want to provide that emotional support to them. Inclusion of sexual orientation and gender identity and patient employee discrimination policies. So a lot of discrimination policies, non-discrimination policies, may not have this population of people in it. So you can talk to your administration once you're educated on it to maybe add this into the policy for them. Training and cultural competence is another big thing that needs to happen in healthcare that's not really happening in a lot of facilities. And promoting medical homes. Medical homes are places where you go for a doctor's appointment. They have social work, they have case management, they have all those resources there for you to have, for the patient to have. I kind of mentioned teaching coping strategies, advocate for equitable treatment to reduce potential for minority stress. Refer to treatment services, advocate for insurance coverage. Refer to sexual reassignment surgery if that's something that they want to do. You can kind of help them in the process in a step to do that. Promote healthy lifestyle changes and choices. And educate is going to be a big thing for this community. So I saw something online last night on humanrightscampaign.org. So they did a post where 121 companies signed a petition called Business Statement for Transgender Equality. And basically it's to help support the transgender population, because the Obama administration kind of, they said loosely, looked at the transgender loosely and open up avenues to where you can identify yourself kind of how you want. But then the Trump administration wants to change that and identify everyone by their genitalia, which kind of, as their word is, erase the transgender population. So that's something that's going on right now. He was posted yesterday that he's trying to have it just by your genitalia and going back on what Obama did, which changes a whole lot for this population. So they're definitely fighting against that because they're knocking them out of a lot of services that they're getting. So I have a few questions. Anybody have any questions before?
Can you go over the terms, the
phalloplasty and like those terms?
Okay,
Basically
so
just
phalloplasty is
phalloplasty.
the formation of a penis. So if you have a transgender transgender male, they can have a penis formed from the skin of their arm, they take it from, or the thigh on the leg. So that's something that they will have, and what comes with that is they will have a phobia for approximately the education. I mean, the literature says about a year, because the urethra has to form and stay open and not constrict. So when they're at home, hopefully they're pretty healed, but if they're not, you're going to be nurse care for them and observing those sites and making sure that things are taken and that they're doing the things that they're supposed to do.
Thank you.
Regarding like the health promotion, we talked about like the confidential care, which is all about like HIPAA. But when we're talking about like informing, like they can't inform the parents, because a lot of them are coming out younger and they might be under the 18. If the parents asked,
you can't tell.
You still, because that's like a.
It's a HIPAA law. So for instance, I took my son. He was 12 for his physical. The doctor asked me to leave, and whatever they talked about was them, HIPAA with them, even though. And I had an issue because we paid the insurance. I want to know if my son is doing drugs. So you want to tell me or not? No, you cannot.
And there are specific provisions, anything related to reproductive care. That's where you don't necessarily have to inform parents. So it's true that the healthcare provider doesn't inform the family of any issue related to reproductive concerns. However, that can be broken in the event that there's risk to the child is at risk to harm themselves or harm someone else. But it's true. So we can treat somebody and talk with them about reproductive care and actually provide birth control, but we can't necessarily treat them for strep throat without consent because they're two different pieces of the law. So that's why anything related to gender identity and gender issues falls under the guise of reproductive care, so therefore it's protected. Does that make sense?
Or another example is 15-year-old that come to the ED, they have the STD.
Mm-hmm.
We can't inform the parent. Even if we call them, the parent answers the phone, we can't inform the parent. And if the parent make the child put the phone on speaker, there's nothing we can do about that, but we can't. Any other questions?
You said that adolescents are usually like they can be homeless and then survival sick. What is that?
So if they're homeless and they need food to eat, or they need a place to stay, they can have sex with someone for money to eat. Because if they're homeless and not getting anything from their parents at all, even if the parent wants them to come back, they may not want to go back. So they do whatever they need to do to survive on the streets. So a few questions. All patients require preventative care and testing. Therefore, the transgender male, 40 years and older, should receive good preventative care tests done yearly. So it's a transgender male, 40 years old. Any guesses? Mammogram. Because a transgender male was a female. Transition to a male, so they still have breasts, they still need to get breast exams. Part of the preventative care. Transgender women and men take medication to change their physical appearance. What are some health issues that can arise in transgender women as a result of hormone replacement therapy? Anyone? Because transgender women and men have a lot of psychosocial issues, what are some disparities or factors observed in the transgender community? Which statement is true for transgender women versus lesbian women regarding health care? That's it. Any other questions?
Which one was that?
Two.